This podcast contains strong language and adult themes that may not be suitable for all audiences, including discussions of medical assistance in dying, MAID, end-of-life decision-making, and death. The content reflects MAID policies at the time of filming and may not represent current regulations. This material may be distressing to some listeners. Discretion is advised.
I'm Daniel English. I'm a four-limb amputee and a power wheelchair user. And this is Frederick Croach. We're the directors of Crip Trip.
It's Danny and Fred. They're the Crip Trip Podcast.
Hello and welcome to another Crip Trip Podcast. Today we're joined by Dr. Tanya Stefanski and Christina Rumsey, two professionals in the health tech and policy division at U Alberta. They were part of a massive I don't know if meta-analysis is the right word, but study that looked at families and impacted persons around medical assistance in dying. Thank you so much for joining us today. Can you guys give us a bit more of an introduction?
Sure. My name is Tanya, and I'm Director of the Health Technology and Policy Unit at the School of Public Health at the University of Alberta. And that unit does evidence reviews to inform policy decisions that are brought to us by ministries at the provincial or federal level.
And I'm Christina. I'm a PhD student at the School of Public Health, worked with Tanya on this report for Health Canada, and I'm a social worker by profession.
Awesome. And can you guys kind of describe what the MAID program is and kind of the evolution over the years?
So the MAID was introduced in Canada through a combination of court rulings that began in 2015 with the case of Carter versus Canada. It was a Supreme Court decision brought about as a result of a case that was launched by the British Columbia Civil Liberties Association on behalf of two plaintiffs, one named Kay Carter, who had medical assistance in dying in Switzerland because she had degenerative stenosis and couldn't get access to it here, and Gloria Taylor, who had ALS. The unanimous decision out of that was that prohibiting, so the criminal code prohibits medical assistance, or did prohibit medical assistance in dying. And the finding was that ban basically violated a person's Charter of Rights and Freedoms. So as a result of that, Bill C-14 was introduced, which enabled people who had a foreseeable natural death to have access to MAID. Then in 2019, there was a Superior Court decision in Quebec called the Truchon decision, which said it was unconstitutional to limit MAID to people who just had a natural foreseeable death. That led to Bill C-7 in 2021, in March of 2021, which enabled people who did not have a foreseeable death, but who had a egregious and irremediable condition, and who felt that they were experiencing intolerable suffering, to be able to access MAID. And then between then and now, we've had Bill C-62, which has basically put off a decision on a third track, which would enable people with a sole mental illness to be able to access MAID. So Bill C-62 puts off a decision until March of 2027 to enable people with mental illness to access.
And how prevalent is the use of MAID in the world? So Canada has this program. Do other countries have it as well?
Yeah, there are quite a number of countries that have it and are developing it. So for example, the United Kingdom is bringing forward, I think they've brought forward legislation now. Theirs is different in that it is only for people with a foreseeable death, and they've done things differently. So they've said their individuals have to have a 6-month prognosis, for example. So countries vary in how they do it. And there were countries before Canada who had done it, and Canada looked to them, to kind of look at how they would implement or create legislation to begin with.
Well, and I know some of the recent critique was worrying about the rates that we were accelerating a little too quickly. So Are you aware of whether it has leveled off a little bit? I think from what I saw in the 6th annual report on MAID that we're now at like a 9% increase as opposed to like it was in the 30% before that.
Yeah.
So it's beginning to level off a little bit.
You're correct. They say the rate of growth is decreasing, although the numbers increased for 2024. They're saying that rate is decreasing at this point.
Can you give us an idea, like what do you mean by increasing rate, and how does this compare to other countries? Is it a lot?
What we understand is that Canada is the fastest growing country in terms of MAID. I don't know where that is at this point now, but that was the concern not long ago. So that is, information doesn't get shared in the MAID health reports, but that is a concern that we've been very quick. The health report is saying they feel it could be leveling off, as you say.
Absolutely. And I'm looking at a list here, and it's saying MAID provisions in 2024 around 16,000. And then there's some ineligibilities that were compounded. So it sits at around, I want to say, 5% of the total deaths in Canada. Is that accurate? I believe.
I think you'd have to look to the report for sure. They would have the most accurate statistics. That we didn't look at that in the report that we worked on. But yeah. As far as I'm aware, that's accurate. Can you talk a little bit about how Track 1 and Track 2 are different, and what kind of systems are in place for deeming whether or not someone is Track 1 or Track 2?
So Track 1 is for individuals whose death is naturally foreseeable. So they have a naturally foreseeable death. Whereas Track 2 is a non-naturally foreseeable death, but they have egregious or irremediable conditions that make suffering intolerable. So in order to determine whether someone is Track 1 or Track 2, there are criteria in place to do that. But the criteria are fairly non-explicit. So for example, what defines a naturally foreseeable death? So the terminology in the legislation is naturally foreseeable death. Is that 6 months? Is that 2 years? And what we found is that when we asked assessors how they determined that, it varied. It was very much, based on their individual experiences. They might have programs that give some guidance or some general procedures for determining that. So scales, questions that you could ask. But fundamentally, what assessors told us, it's very much their individual experiences that help them to determine what is naturally foreseeable, which is why you get that span of weeks all the way to years considered naturally foreseeable. And then in the non-naturally foreseeable, some of the safeguards there are that there's a 90-day assessment period where you would have multiple potential assessments with an individual because they're not basically seen as having a foreseeable death, but you have to make sure that they've understood all of their options, that they don't want to try anything else, and that there's some expertise involved to state that this condition is actually just going to continue to cause suffering.
Yeah. And, even with our friend Brian, he talked about the 90-day kind of waiting period that they make you take after you've decided to go.
Our friend Brian McPherson went through Track 2 a few months ago. It was Track 2, right? Yeah. It wasn't a foreseeable death. No. And he told us when we were chatting with him in an interview, he said, even though this is something I want to do, I feel it was way too easy. And they didn't really give me any psychological evaluations. And I was kind of shocked when he said that, because in my mind, I'm like, well, then why did they let you do this? Shouldn't the government be giving you an evaluation before they state-sponsored execute you?
Well, and that's the precarious spot that I think clinicians are being put in, is that without codified, federal legislation that translates into the, provincial jurisdiction as well, not having any continuity there can sometimes lead to, things being easier in one province than maybe another. So maybe this is a good time for you guys to talk a bit about what your study was and some of the findings. Maybe start with a little bit of methodology, like who were you interviewing? Who were the stakeholders that you were evaluating?
So this was a review commissioned by Health Canada so that they can understand how MAID had been rolled out across the different provinces and territories. So the federal government sets legislation, but it's up to the provinces and territories to implement that legislation through operational policies and procedures. So we were asked to find out what that looks like across provinces and territories. So we interviewed folks involved in the MAID services in each province and territory. So those would be things like program coordinators, if there was one, medical directors, administrators, in some cases policymakers within the ministries of health who might be involved in strategic policy direction. It included assessors and providers, MAID coordinators, in some cases social workers. So folks who were involved in the delivery of MAID services. So there were 86 of them we interviewed across provinces and territories, usually more than one in provinces, so that we could make sure that we got a more fulsome view of the way services were delivered in a particular jurisdiction. Then we were also asked to interview families. So we interviewed 34 families and friends of loved ones who had proceeded with MAID to get an idea of what their experiences were like as a result of the systems and the processes that were in place. And we did also talk to providers and administrators about, well, what do you think are the facilitators and the barriers to the implementation of MAID? So it wasn't just descriptive, it was also their opinions around what they thought was working and what they thought, wasn't necessarily working. So that's what we were asked to do.
And did you hear a kind of common through line, at least on the provider's half, about continuity or guardrails they think should be there? Or because it's a pretty unenviable position, I think, to be in, where you're having to weigh the individual's autonomy with almost a paternalistic look at whether or not they've considered all of their options. And it's easy as disabled people to, malinger or lie or do whatever you need to try and, fit a certain criteria to get through a program. How do we make things like this safe if, there's that much precarity in the assessments?
It's interesting. I think the people who we interviewed were some of the most passionate healthcare providers and administrators we've ever come across. So they're very passionate about MAID and offering a service that they feel should be part of any care set that's offered. So I think there's a certain set of individuals who are attracted to being involved in MAID, because nobody says to a provider or an assessor, you have to do MAID. Mm-hmm. So this is a choice. So I will say that there was a passion there among the people who we spoke to basically make sure that MAID was accessible to people who wanted to have access to it. I think in terms of the assessment, you're absolutely right. Part of the challenge there is clinical judgment, which is subjective. The safeguard in place is to have 2 independent assessments. What we did learn is that independent assessment looks different depending on where you are. So you and I might think independent assessment would mean that there's a first assessor and then who does their assessment, and then that first assessor submits their assessment, and then there's a completely independent second assessor who knows nothing about what the first assessor said, and then independently submits their information. That happens somewhere, but not everywhere. So in other cases, the view is that 2 assessors can talk to each other because in the end, they're still making their own decision. But they have those conversations, so they would share the information. So I think that in itself may not be clear to people. So an independent assessment, some people would say our assessment took a very short time period. Others would say, the assessor spent an hour or two with us. So, and I think Christina can probably speak to that a little bit more closely, because that is an area where I think a lot of the concern was raised.
I would say along with that families were talking about that comprehensive and accurate assessments and really wanting to make sure that was completed. So for some families, they did feel like that was done. Others shared, stories of that they weren't involved in the assessment at all. And that was concerning to them because their family member had mental health issues along with medical diagnoses, had addiction issues in a couple of examples of family stories. So they were concerned about that accuracy and making it as comprehensive as possible. We also had families, a family member talked about being in the hospital and having a phone call, the doctor, the assessor saying, I don't need to meet with you. I've seen your medical records. So the family then saying, is that enough?
Yeah.
And so, that sort of piece of wanting to advocate strongly and meet the request of a patient and family versus are we always ensuring that, or are we clear that we've got a comprehensive picture? And then some families said, so for us, that meant we actually were hoping for more. We wanted to talk about options. We wanted to make sure at least that they were discussed in full, which is part of the requirements of the assessments.
So something that we've heard from a lot of people in the severely disabled community is one of the critiques have made is it feels like it's easier for the government. It's cheaper. It's easier. It's more efficient to kill us than it is to help us. Did you guys come across any of this sort of sentiment when doing the research?
That's it. That's interesting because when we asked for reasons that loved ones had decided that route, things like, I don't want to die bankrupt with leaving my family nothing. I don't want to be stuck in long-term care. I don't want to be suffering. I can't get the home care I need. Were there some other examples that you can think of?
Sort of that continuity of care then, that my family member didn't get the constant care that they needed, and now they've ended up asking for MAID.
There was sometimes a sense that people just gave up and that they were tired of fighting the system. And there absolutely were financial concerns. They didn't want to put that financial burden on their families trying to scramble to provide the care that they felt they couldn't get in a system.
I think also caregiver burnout, that was another kind of challenge for families. And I certainly didn't get the sense, I don't think we felt that the healthcare professionals were sort of thinking that. I don't think at all that was the sentiment of healthcare professionals saying, this is just easier. Absolutely not. I think, though, that what may be missing at times that we heard from families was, we had all these challenges along the journey, and that may be, in some cases, that is what has led us to this place of our loved one wanting MAID. So did anyone look at? So you're telling us you didn't get enough home care hours. So how can we help you with that? Versus, okay, we hear that, and now we're going to help you have MAID. So it may be a bit of, we need to connect those together. There has to be that comprehensive assessment that takes place, and that takes resources. It takes time. So efficiency is not always. We want to be efficient, but we want to be comprehensive. So we need to make sure that comprehensive assessment is there first.
Absolutely.
And I think,
this is a major thing.
It
should have the most assessment possible.
But I think, too, there were even MAID people we spoke with. So people who were coordinating MAID, intake people, so people who would receive the request, who said that it wasn't until they understood the stories that they realized how many problems our system had. Because these guys were coming to MAID because, in some cases, they were being evicted from their homes. These patients didn't go on to receive MAID, but it was an eye-opener for many of the MAID folks to realize just sometimes how broken our system was, that they didn't realize. And then they were doing the work of trying to investigate how they could help these people outside of their MAID program. And this is where, a person has to think about, where does the MAID program fit or sit within an organization? Because, if it were more integrated into the services, there might be a better sort of continuity of care to your point, Daniel. So, the question is, if we really want to have integrated care in Alberta, which is something that Alberta is trying to work on, then how do we ensure that happens? So what are the resources that need to be in place, especially in a system that is resource constrained? So what do we need to do in order to do that? Because sometimes the folks who in the programs, like the providers, the administrators, were saying, we know that we should provide more psychosocial support. But where are we going to get them? Because they'll say, when we established this program, we were seeing this many cases a year. Now we've grown exponentially, but our financial or our budget didn't increase to support those things. So I think sometimes there's an awareness among those even involved in MAID programs about the need for more psychosocial support. But the question is, where are these resources going to come from? And they did talk about the lack of coordination and collaboration that sometimes happens between the MAID program and the rest of the healthcare system.
As a follow-up question, did you notice when you were evaluating the family's, take on the MAID journey, was it ever just particularly discordant with the MAID applicants' intention? Like, how often were the families angry, at the individual's decision?
We did have a number of families there were families who were very supportive, and then we had a number of families who did share experiences where they were not involved at all in the MAID process, which was highly distressing to them. And one family member said, we just needed someone to help us come together with our family member and have discussions. We needed that facilitation. And even if we didn't come to an agreement, that at least we could have figured out how, we could have been there when they died even. We could have held their hand. They wouldn't have been without us. So that was a challenging piece of family members not in agreement, but still wanting to be with their family. So these weren't family members who were estranged. They were very much involved in their loved ones' lives still, but somehow they were not involved in the MAID process. We had another family member who, her mom was in the hospital. She'd been calling her. She had arranged to get clothing to her. She was planning on coming to see her in a couple of weeks. And then she got a call out of the blue from the physician saying that your mother has died from MAID. And she said, you must be mistaken. This can't be, you're talking to the wrong person. She was in complete and utter shock and distress. And she again said, why didn't you talk to me? Why didn't you bring me into the conversation? And now I'm in this position of just being, had this horrific experience that has changed her life forever.
That sounds like the sort of thing that might happen when you rush something, and this probably isn't something that should be rushed into.
The other piece of that, and I think that is, sort of the within legislation and that whole what brought in the legislation, and I think what people become passionate about is this autonomy, wanting to make sure that people have the autonomy. And I think what families said to us was, they can have the autonomy. How can you help us to bring us together still? Because even though it doesn't mean that you kind of destroy our lives, affect them in a horrific way that will never leave us, of course. How can you help us as a system to make sure that at least we have conversations together? That's an important piece. I agree that I don't even know if it's about that piece about rushing. I think it's that when the family member says, "Don't call my daughter," then do you just say, "Okay, I won't"?
Well, this is that whole trouble with patient confidentiality. So that was something that was brought up a number of times. Well, we couldn't have reached out to the family because there's patient confidentiality involved. And, that's fair. But what about if there was that sitting down with that patient, having those gentle conversations, maybe not just that, because oftentimes we'll say something kind of flippantly, right? And then someone comes and talks to us a little bit later about it. There might be that opportunity to maybe change our minds or to reconsider things, but that didn't happen. And so that's where that psychosocial component comes in. And I understand that in resource-constrained environments, maybe people are just hoping, okay, well, check that box, patient confidentiality says, nope, they don't want us to tell their family. But there's that thinking holistically about, well, hang on a minute here. This is not just any old medical procedure. There are no do-overs at the end of this. So should we really be treating this just like a medical procedure?
Well, and even in, context of things like a therapist treating suicidality and patient confidentiality there, or, the other thing this kind of reminds me of is the death penalty, right? Like, we had a Supreme Court decision saying any mistakes is too many, so we're going to get rid of the whole thing, right? I think it's interesting to see...
It's a morbid comparison.
Yeah, but I think it's interesting to see how, hands-on the government is getting in some instances versus others, and I think that is one of the most nuanced parts of this, is that aspect of autonomy, and if the person is choosing to. But then you look at, things like systemic coercion, where it's a lack of resources that are driving people, to seek MAID. It becomes a balancing act of where we prioritize our health resources too, right?
Right.
Was it challenging for you guys to have to work on a report like this, digging through what are just endless stories of suicide? Was it a challenge?
I think it just brought to light for me more the concerns and the issues and the things that we need to look at, which is in some ways it oddly might have made me feel better that we've done a report that hopefully will have some impact, that we've been able to bring to light some gaps and some needs, and that may make a difference. So I would say that in that way, it actually made me feel better.
Yeah. And I think it was probably one of the most impactful pieces of work I've ever been involved in my career, because I do think that we can probably do better, and I think it's always helpful to have the one-off cases, but when it's all together in one report, I think that's helpful for policymakers because they've got one place to go to kind of get a snapshot of where we are. And I think that will also help when we look towards that third track. And what is it that you really need to have in place to ensure that the spirit of MAID is actually being rolled out that way, rather than maybe in what can often seem as almost reckless ways. So I don't think anybody wants to see people suffering, whether it's a single mental illness or multiple comorbidities. But we have to make sure that we have the right safeguards in place that are much more explicit, I think, than are in legislation right now, to ensure that we are respecting what I think even Canadian values are. So I think the other big thing is, where do Canadian values fit into all of this? Because I don't think we're a society that just sort of wants to make it so simple that the value of a life becomes diminished.
Mm-hmm.
A last thought. We sort of discussed the track 1, which is imminent death. Track 2, which is more a lot of chronic pain.
Yeah.
Now we have this track 3 that will be coming up. What exactly is the track 3? And I feel like the talk in the disability community is kind of worried about this track 3.
So track 3, which is just sort of an informal way of saying it, they haven't defined it as track 3, but it would be a third track, would enable people with a sole mental illness or mental health issue to access MAID. So there doesn't need to be anything else wrong with them. So right now at track 2, you could have a mental illness, but you also need to have an egregious, irremediable condition. So that's the difference. So the a single mental health illness might be, schizophrenia, something that's untreatable. So meaning that person might have a form of schizophrenia where nothing seems to help them, but that's all they have. So in order to make sure that those assessments are done, you need psychiatrists, you need the right folks in place. Those are things we have a shortage of in Canada right now. So that's the big concern that healthcare systems are facing is we don't have enough psychiatrists as it is. If you're going to introduce this in a safe way, we're going to need to figure out what those resources need to look like before we implement this.
And if people want to check out the report, is this something that's available? Where do they go if they want to read about it?
It's on the Health Canada's website. Yeah.
Okay.
Awesome. Thank you so much for joining us and elucidating some of the, ethical conundrums and important family aspects.
I think I've heard something like every Canadian knows someone impacted by MAID at this point in time. And I mean, these are like really important conversations that the public should be aware of. Thank you so much.
Thank you.
Thank you for having us.
AMI Plus. TELUS Fund. TVO. A Catapult Pictures production.